appreciation for accepting our invitation to moderate this panel. Thank you very much, and the platform is yours.
Thank you, Dr. Shaki, for your nice and kind introduction. It's really a great honor for me to be here. Thank you for inviting me. And I'm very excited because of the very interesting program we are going to have today. We will have two speakers. The first one is Dr. Hana Safar, who is a pathologist from Tehran University of Medical Sciences. She is a colleague of mine in Cancer Institute, affiliated to Tehran University of Medical Sciences, and she is a very talented pathologist in our department, and he is an expert both in soft tissue and bone pathology and head and neck pathology. And I think the topic that you have selected, Dr. Shaki, for Dr. Hana is very good. You know, it's related to soft tissue malignancies of head and neck, and I think she will be one of the best speakers for this part of the program. And the second part and the second lecturer will be Professor Jerry Boko from United States. And I'm very thrilled and I'm very happy that we have him over here. Jerry, thank you very much for accepting the invitation of the organizers of this program. He is a distinguished oral pathologist, and he has more than 400 papers, abstracts, book chapters, and also he is one of the editors of one of the most well-known oral and maxillofacial pathology textbooks, and we are very happy to have you over here, and welcome to the lecture. Okay, if you agree, we are going to start the lecture with Dr. Hana Safar. Stage is all yours. Please start your lecture.
Thank you, dear Professor Azmude. Thank you for a nice introduction. First of all, I have to say that it's really my pleasure to participate in this short course with expert head and neck pathologists. I'm not, of course, I'm not expert at all, but I am interested in learning, and I'm trying to learn head and neck pathology, soft tissue and bone pathology, and this is just I have learned during these years. Just I am sharing my experiences and others experts experiences, of course. And if it's no, I'm really excited to I'm participating in the conference with Professor Boko, who is an expert, well-known international head and neck pathologist. So I think I hope it will be useful for all of you. Thank you so much. Can I share my slides?
Okay, if you can share your slides. Okay, good. Now we can see your slides, and we are all ears to hear what you are going to tell us about head and neck lesions, soft tissue tumors.
Okay. As you know, today we are going to discuss about head and neck soft tissue head and neck lesions. My focus is on speaking about malignancies and locally aggressive tumors. Okay, let's start. As you all know, soft tissue sarcomas are a heterogeneous group of tumors, And if we don't follow, I think, an appropriate approach, it will be very challenging in most of the cases. And I think it's better to follow an approach, a systematic approach. One of the best approaches, I think it's better for me to, um, so I want to make my microphone off. Okay, so I think it's to follow an approach. One of the best approaches I have found um, is provided by this article from Italy. Um, of course, there are lots of approaches, but I have found this approach very useful, and it's close to 2 years that I use this approach in my routine practice. Of course, you can easily find it on the web. And today we are going to discuss our cases with the same approach. At the very first part, when you encounter very soft tissue neoplasm, it's better to pay attention the shape of neoplastic cells. Neoplastic cells can have different shapes. For example, they can be spindle, they can be pleomorphic, they can be epithelioid, and they can be round in appearance. And of course, mixture of shapes can happen. For example, a lesion can be a spindle pleomorphic. It can be a spindle epithelioid. So it's better to first, at the first part, pay attention to the shape of neoplastic cells. After that, it's better to consider the pattern of growth of the tumor. The pattern of growth can be fascicular, can be herringbone, can be storiform, can be alveolar, and can be biphasic. Of course, they are main part, and other patterns also do exist. Today, we are going to discuss about these patterns in detail. After pattern of growth, it's better to evaluate quality of the background of tumor. The background can be fibrotic, sometimes dense fibrosis and sclerosis. Sometimes it's myxoid, sometimes it's chondromyxoid, and it can be even osteogenic, like extraskeletal osteosarcoma. Sometimes the background is completely osteogenic. Even the tumor is completely located in the soft tissue. After that, it's better to pay attention to the architecture of the vascular network. Some patterns do exist. For example, hemangiopericytoma-like pattern, arrangement of neoplastic cells around vascular channels can create a hemangiopericytoma-like pattern. Vascular channels are somehow slit-like and compressed by tumor cells. Vascular architecture can be plexiform, the pattern we usually see in myxoid liposarcomas, and it can be archiform, like, for example, low-grade fibromatosis sarcoma. So we have different vascular networks. I think it's a good approach, and today we are going to discuss our cases in this way with this approach. Okay, let's go to the first case. The first case is a 6-year-old girl with submental soft tissue mass. Let's see. As I mentioned, the lesion is located in submental region. You can see mandibular gland here, submandibular gland, salivary gland, and here you can find your lesion. Here the border is sharp. I think here that we have a sharp border. But as we can approach, according to the approach that I mentioned, it's better to first pay attention to the shape of neoplastic cells. Here we have a low power slide, but I think at this low power, we can still appreciate that the lesion is spindle shape. Neoplastic cells are spindle in shape. And they are arrangement. After shape, we have to pay attention to the arrangement of neoplastic cells. They are arranged in long fascicles, as you can see here. And after that, we are going to the background. Background is fibrotic. Sometimes it's fibrotic. Here you can find some dilated vascular channels, thin valvascular channels, and a clear halo zone around some of the vascular channels. In this slide, again, you can see spindle-shaped neoplastic cells and fascicular arrangement in a fibrotic background. As you can see here, there is no atypia. We can neoplastic cells seem to be very bland looking. They are not hyperchromatic. They are not bizarre. They are not pleomorphic. They are just bland looking spindle cells. Okay, in this high-powered slide, we can see shape of neoplastic cells more better. Here you can see the nuclei. The nuclei is spindle-shaped as I discussed, but we should be careful because spindle cells are also divided to different types. For example, you can here see that the end of this neoplastic nuclei is somehow tapering. This is tapering in both ends, and this is characteristic of fibroblastic or myofibroblastic cells. For example, when you encounter smooth muscle neoplasm, the nuclei tends to be blunt in end. In both ends, they are usually blunt. And maybe not all of neoplastic cells, but if you search thoroughly, you can find some of them at least. But for fibroblastic and myofibroblastic cells, the nuclei show tapering ends. Nuclei of neoplastic cells show tapering ends. So it seems that this lesion is fibroblastic or myofibroblastic in origin. And here you can find a vascular channel and a zone of clear halo around this vascular channel. In this slide, you can find skeletal muscles which are infiltrated by neoplastic cells. So we see that although it was a sharp border between the lesion and submandibular gland, here in other borders, the lesion is somehow infiltrative and adjacent skeletal muscles are infiltrated by tumor cells. So, in summary, we have a child, a 6-year-old child, with a spindle cell neoplasm, no significant atypia, no significant mitotic figure, and we have a fibrotic background, and it has ill-defined border, at least in some portions, like this slide. And we don't have a significant vascular meshwork like hemangiopericytoma, like archiform or plexiform. There's no significant vascular meshwork. So when we want to approach to this neoplasm, one of the best diagnoses that we can make is desmoid type fibromatosis. Desmoid type fibromatosis is by definition a non-metastasizing, locally aggressive tumor. Cytology is bland. It's about 10 to 15% of cases occur in head and neck region. Macroscopically, they are tan white with areas of whorling. Sometimes they seem to be well delineated, and sometimes they're really ill-defined in border. Microscopically, the lesion, neoplastic cells are arranged in long fascicles. Spindle cells have tapering vesicular nuclei and indistinct cytoplasm. Background is fibrotic, and there is no pleomorphism, and mitotic figures cannot be easily found. On IHC study, neoplastic cells show positive nuclear immunoreaction for beta-catenin in 70 to 75% of cases. Actin is usually positive, like my fibroblastic cells in a tram track-like pattern, and this mean can be occasionally positive as well. So, but this is straightforward up to this part, but we should be careful because there are some lesions mimicking appearance of this desmoid type fibromatosis, but they are not exactly desmoid type fibromatosis. One of them is desmoplastic fibroma. We should be careful, and we should, as in every soft tissue and bone tumor, we have to correlate with clinical radiological findings. As you know, desmoplastic fibroma is again a locally aggressive bone tumor with histology identical to desmoid type fibromatosis. So the location is very important. For example, if the lesion is with similar histomorphology is located in bone, we call it desmoplastic fibroma. And if it's located in soft tissue, we call it desmoid type fibromatosis. Sometimes it's not that much easy. For example, the lesion is located in the bone, but it has a soft tissue components, or vice versa. So at least in most of the parts that is possible for us, we have to pay attention to radiological findings, because one of them, although desmoplastic fibroma is a rare tumor, one of the main location is mandible, and it shares the location with desmoid type fibromatosis. So, on my gross examination, this lesion is again firm. It can have hard architecture. Histomorphology is identical to desmoid type fibromatosis. And but IHC in IHC staining, they have some differences. For example, in desmoplastic fibroma, beta-catenin is not seen as we can see in desmoid type fibromatosis, and some authors believes that in desmoplastic fibroma, the pattern of staining of beta-catenin is more cytoplasmic rather than characteristic nuclear staining of desmoid type fibromatosis. But again, at least this lesion is again not malignant, and it's a locally aggressive tumor. But another lesion which is malignant and has significance of diagnosis, this is the slide from WHO classification of soft tissue and bone tumors, and it's desmoplastic fibroma, and as you can see, is exactly identical to fibromatosis. But another lesion which is not locally aggressive and it's malignant, although low grade, it's myfibroblastic sarcoma, also called low grade myfibroblastic sarcoma. The mean age is about 40 years, and localization is oral cavity, including tongue, nasal cavity, and paranasal sinuses. It's more common in oral cavity, particularly tongue. So we have to pay attention to microscopic findings very carefully. On gross examination, these lesions are again firm, fibrous, they have fibrous cut surface and poorly defined borders. On microscopic examinations, again, we can see fascicles and sheets of neoplastic cells. Sometimes there are alternating areas of hypercellularity and hypocellularity. They can have focal hypercellularity, hyperchromasia, and herringbone pattern, and sometimes we can find areas with high proliferative mitotic activity in these tumors. The background is sometimes more collagenous, sometimes more myxoid, but in some regions, at least, for example, for diagnosing in small biopsies, we should be careful in order not to miss a low-grade myfibroblastic sarcoma. On IHC study staining, unfortunately, there is no specific IHC marker for diagnosis of this tumor. Some markers, general markers, general smooth and myfibroblastic markers like SMA, desmin, and calponin can be positive. CD34 can show variable staining, and the prognosis is not that much bad, and metastasis is rare, and they tend to occur locally, recur locally. Sorry. And this slide is a low-grade myofibroblastic sarcoma from WHO classification of soft tissue and bone tumors. As you can see here, somehow herringbone pattern. Today we are going to discuss herringbone pattern. Sometimes you can, if you want to follow the approach, again, cells are neoplastic in shape, tapering ended, background is fibrotic. We have to search for hypercellularity, for hyperchromasia, for mitotic figures. So in this way, we can be certain that we are not going to miss this lesion. Okay, the second case. The second case is a 28-year-old female with neck mass. Okay, in this low power slide, you can find areas of myxoid changes. Sometimes fibrotic changes are present as well, but the main part is myxoid. If we want to approach to this case, it seems that neoplastic cells are at least oval to spindle in shape. The lesion is in this slide very hypocellular, and the background is myxoid, no significant vascular meshwork is present. So we have a low cellularity neoplasm with myxoid background. Okay, in this high power slide, we can see neoplastic cells. Some of them are serpentine in shape. As you can appreciate nicely here, you can see here, they're serpentine. And in contrast to the cells we described in desmoid type fibromatosis, which they tend to have tapering nuclei. Here you can find in one part the neoplastic nuclei is blunt ended, and in one part it's somehow tapering, but it's not like myfibroblastic or fibroblastic cells. So the cells are somehow different. Some of them have comma shape. You can have pointed end here, for example. They are reminiscent of comma. So there is a background which is somehow fibrillar. So we can, in summary, we have a neoplastic cells. We have a neoplasm composed of spindle-shaped neoplastic cells with serpentine and comma-shaped nuclei, fibrillar myxoid background, no prominent vascular meshwork, and then we go to other slides. Okay, look here, please. Here it seems that the lesion is in this slide more cellular, and cells have degrees of atypia, hyperchromasia, nuclear enlargement, and even you can find mitotic figures here. And the arrangement is somehow fascicular. It's not like scattering of cells in a previous slide. So you can see here that you can feel that something is going to happen in that blunt-looking neoplasm. And here you can find areas of hypercellularity and hypocellularity, alternating areas, creating a characteristic marble-like appearance. Here you can find long fascicles. Again, cells are spindle in shape. They are arranged in fascicles. The background is myxoid, and there is no prominent vascular meshwork. Okay, look here, please. Here you can find some of the neoplastic cells. They are arranged around vascular channels. They are somehow, we can find condensation of neoplastic cells around vascular channels, creating prevascular coughs. So, again, you have alternating areas of hypo and hypercellularity and prevascular coughs. Here, Again, you have arrangement of spindle cells in long intersecting fascicles, creating a characteristic herringbone pattern. And again, you have a vessel here and perivascular cupping of neoplastic cells. Here again, there is somehow reminiscent of herringbone pattern. In the next case, I'm going to discuss herringbone pattern in more detail. And again, the background is somehow myxoid. Okay, so the diagnosis is malignant peripheral nerve sheath tumor. To be honest, our case was a known case of neurofibromatosis type 1. And I selected this case because I wanted to show that in these patients, we can have spectrum of nerve sheath tumors. We started from neurofibroma and we ended in malignant peripheral nerve sheath tumor, high grade. We had areas of extensive necrosis in our specimen. So I just selected this case because of this. We have to be sure that we are evaluating representative sections from our specimen. By definition, MPNSTs arise from peripheral nerves or sometimes from previous benign nerve sheath tumors or some at the same time like our case. About 20% develop in head and neck regions, and about 25 and to 30% are associated with neurofibromatosis type 1. Cranial nerves and vestibular nerves can be affected. On cross-examination, they may be within a nerve trunk or they can be attached to a nerve trunk. And they are most of the time creating a fusiform appearance to the nerve trunk. And on microscopic examination, they are usually well delineated, unencapsulated. They are infiltrative areas of necrosis, and cells are spindle shaped. Sometimes they are epithelioid. We have epithelioid MPNST with special significance I am going to tell you. Sometimes the neoplastic cells are pleomorphic and small, maybe. But one characteristic feature is alternating areas of hypo and hypercellular areas, creating marble-like appearance. And another characteristic feature for MPNST is prevascular cuffing of neoplastic cells, as I showed you in that slides. Based on IHC findings, unfortunately, S100 is neither sensitive nor specific for diagnosis of MPNST. Scattered immunoreaction can be seen in about 50 to 60% of neoplastic cells, and SUCCET10 is with same sensitivity and specificity, of course. There's another recent marker which is called H3K27ME3, and recent studies have shown that loss of expression of this marker is present in up to 60% cases of MPNST. And it's more searched in the setting of neurofibromatosis type 1 disease. I'm going to show you the picture slide of H3K27ME3, but there is an important point that we should consider. When we encounter an epithelioid neoplasm with a strong immunoreaction for S100, we should consider two main diagnoses. We have two main differential diagnoses. The first one is malignant melanoma. Sometimes you know that malignant melanoma can be epithelioid in shape, and the first one is epithelioid MPNST. We said that MPNSTs are not, they don't show strong immunoreaction for S100, but epithelioid MPNST tends to show a strong immunoreaction for S100. So please keep it in your mind and in order not to miss epithelioid MPNST. Here is a very good article from my clinic updates discusses updates of peripheral nerve sheath tumors, and I borrowed this picture from that article. This is in PNST, and here you can find loss of H3K27Me3 in neoplastic cells, and as you can see here, the endothelial cells of vascular channels showed immunoreaction. Okay, and this is a table from a current edition of WHO Tumors of Bone and Soft Tissue. It's, of course, this classification is more useful in setting of neurofibromatosis type 1 disease, but there are some studies that believe that it's going to be applicable for sporadic MPNSTs, nerve sheath tumors too. On the top, you can find neurofibroma, and at the bottom, it's MPNST high grade. And all these lesions are in between. Sometimes we have just plexiform neurofibroma. In the gross examination, we should pay attention to the pattern of gross examination of the lesion. Sometimes neurofibroma just has areas of atypia. There is no significance in these portions. Sometimes neurofibromas are cellular neurofibroma. Again, there is no significance, just we can call them cellular neurofibromas. But sometimes we have ANNUBP. Oh, sorry. ANNUBP. What is ANNUBP? It's a typical neurofibromatosis, a neoplasm of uncertain biological potential. So it has a diagnostic criteria. For example, we should have two or more than two of the following features among cytologic atypia, loss of neurofibroma architecture, and hypercellularity, and mitotic figures should be less than 3 mitotic figures per 10 high power field. And when we go to low-grade MPNST, the number of mitotic figures increases, and it's 3 up to 9 mitotic figures per 10 high power field. And still pay attention that we should have no areas of necrosis. But in high-grade MPNST, the mitotic count is more equal or more than 10 mitotic figure per 10 high power field, and usually areas of necrosis are present. So again, I selected this patient because I wanted just to emphasize that when we are evaluating a nerve sheath tumor, we should be certain, we should be sure that we are these slides that we are evaluating are representative of the whole lesion, and we have to consider these limitations in needle biopsies and small incisional biopsies. About the differential diagnosis, sometimes the cellular schwannomas are in differential diagnosis, but as I said, they are strongly immunoreactive, show a strong immunoreaction for SPON100. Desmoplastic melanomas, SPON100 and they are SPON100 and SOX10 positive. Sometimes monophasic synovial sarcomas, because they can have herringbone pattern, but and leiomyosarcoma because they are again spindle in shape. But fortunately, for excluding monophasic synovial sarcoma and leiomyosarcoma, we have a very good IC panel in order to exclude them from each other. Prognosis depends on site and tumor size, and maybe it's associated with neurofibromatosis, or if the tumor is associated with neurofibromatosis type 1 or not. And that's it, I think. The next case is a 28-year-old man with neck soft tissue mass. Again, don't forget we are going to have same approach. At the very first part, we are evaluating shape of neoplastic cells. As you can see here, neoplastic cells are again spindle in shape, and you are arranged in large long intersecting fascicles in a herringbone pattern. Here again, the pattern is somehow fascicular, but fascicles are not as long as previous slide. Again, we can see that neoplastic cells are spindly shaped. And here in this high power slide, we have some mitotic figures. Can see here, one mitotic figure is here, one mitotic figure is here, and sometimes you can, from the high power, nicely appreciate that the cellular cells are rather uniform in appearance. They are not, we don't see evidence of pleomorphism. And here in this slide, you can find the vascular channels, a thin wall vascular channel, which is somehow compressed by neoplastic cells, creating the appearance of hemangioprecytoma-like. So in this lesion, in some areas, we can find areas of hemangioprecytoma-like pattern. The background is somehow fibrotic. It's not a definite specific background. Okay, so in summary, it's a young man with neck mass, with spindle-shaped neoplastic cells, probably malignant sarcoma. It's based on evidence, we think that it's probably malignant. Spindles, neoplastic cells are spindly shaped. They are arranged in herringbone pattern. It has areas of hemangioprecytoma-like pattern. So let's think about possibilities. One of them is, for example, synovial sarcoma. Another one, maybe it's MPNST. Another one, maybe it can be saltatory fibrous tumor. So let's go and pay attention to the IHC panel. This is cytokeratin A1A3. As you can see, the weak staining is seen in neoplastic cells. This is BCL2, and this is a strong nuclear immunoreaction for TL1. So, of course, we had other excluding markers too. I just selected some of the IC slides here. Of course, we used other IC markers in order to exclude other possibilities. But as I'm going to discuss, this panel is very characteristic for a typical monophasic synovial sarcoma. Synovial sarcoma is by definition a mesenchymal tumor. Based on WHO classification, they are malignant sarcomas of uncertain type. For example, they are not originated from adipocytes. They are not originated from skeletal muscles, skull muscle, smooth muscle. The origin of the cells is uncertain still. And they are among translocation associated sarcomas. Experts of soft tissue pathology believe that sarcomas which are associated with translocation associated sarcomas at all tend to have a very uniform cytomorphology in histologic examination, like synovial sarcoma, like Ewing sarcoma, and some other sarcomas that we are going to discuss. It's a common neoplasm. Head and neck, about 5 to 10% of cases occur in head and neck region. On gross examination, they are usually yellow to gray, and they are somehow well circumscribed with a pseudo capsule around them. And on microscopic examination, they can be either monophasic or biphasic. But when they're monophasic, sometimes they are spindly shaped, sometimes the background is calcifying and even ossifying, sometimes we have myxoid background, and sometimes they are poorly differentiated. And when they are poorly differentiated, they can be small cell in morphology, they can be spindle cell in morphology, they can be epithelioid in morphology, they can be even pleomorphic in morphology. So in the cases of poorly differentiated forms, they are not going to follow that uniform histomorphology anymore. On IRC study, TL1 is positive in about 95% of cases. But we have to consider that only moderate to strong nuclear staining should be considered as positive. Any weak staining can be interpreted as inconclusive. There are also recent IHC markers like SS18. It targets specific translocation, and some recent studies have shown that SS18 can be positive in more than 90% of synovial sarcomas with a good correlation with cytogenetic study. They are positive for cytokratins, spectrum of cytokratins, cytokeratin 7, cytokeratin 19, where for A1, A3, EMA, and other epithelial markers like EMA, they all can be positive. CD99 can be positive in 60 to 70% of cases. And another marker, BCL2, which is not, of course, specific, can show positive immunoreaction. The genetic profile, you know, it's translocation between chromosome X and chromosome 18. And when we are encountering a case of synovial sarcoma, both monophasic and biphasic forms, we have to consider other possibilities like carcinosarcoma. For example, we have to exclude possibility of carcinosarcoma. Sometimes MPNSTs can have glandular structures. So, because in the setting of MPNSTs, the lesion is located in soft tissue, the lesion can have herringbone pattern. So, we have to use a good IC panel in order to differentiate between them. Solitary fibrous tumors. As you know, SFTs tend to show hemangioperitomal-like growth pattern, and this pattern can be seen in synovial sarcoma as well. So we have to use IHC markers in order to differentiate between them. You should consider that sometimes the marker of TL1 can be positive in weak way in solitary fibrous tumor. Another marker which is extremely useful for differentiating between synovial sarcoma and solitary fibrous tumor is CD34. Because, of course, all of the synovial sarcomas tend to show negative immunoreaction for CD34. And another good marker is STAT6, which shows a strong immunoreaction in solitary fibrous tumor, and it tends to be negative in synovial sarcoma. Another differential diagnosis is Ewing sarcoma, particularly when the tumor is poorly differentiated and if it is round cell in morphology in the poorly differentiated synovial sarcoma. Sometimes the differentiation is the diagnosis is extremely difficult, and we have to use cytogenetic studies because they both show immunoreaction for CD91 and for some cytokeratin markers, and maybe for TL1. So sometimes it's very, very difficult to differentiate between poorly differentiated synovial sarcoma and Ewing sarcoma. The prognosis is more favorable in young adults, age less than 25-year-old, and tumors less than 5 centimeters tend to have favorable prognosis and absence of features of poorly differentiation. They are associated with favorable prognosis. In this picture, you can see biphasic synovial sarcoma. As you can see here, glandular structures are present here. So we have to differentiate it from metastatic carcinoma and carcinosarcoma. So this is herringbone pattern, a typical herringbone pattern. What we call herringbone pattern, the name is given from the bones of herring fish. As you can see here, intersecting long intersecting fascicles, creating this appearance. So we call this pattern herringbone pattern. Okay, next case. Next case is a 26-year-old man with forehead soft tissue mass. As you can see here we have surface epithelium, and the lesion is, it seems that the lesion is superficially located. What about the growth pattern? As you can see here, it seems that it's a very interesting growth pattern. Arrangement of neoplastic cells is somehow different from synovial sarcoma and from MPNST. For example, they used to have long fascicles, intersection of long fascicles, but here you can see that fascicles have variable sizes. Intersecting fascicles are in variable sizes. Again, you can appreciate here a pattern which is called storyform pattern. I'm going to discuss about a pattern later. Again, if we want to have our approach, so the lesion is again spindle in shape. The arrangement is fascicular storyform, and there is no significant atypia so far, and there is no specific vascular meshwork, and the background is still fibrotic. So we have a young man with a superficially located soft tissue mass, and these features. Okay, here you can see infiltration of adip underneath subcutaneous tissue with neoplastic cells, creating a characteristic honeycomb pattern. We call this pattern a honeycomb pattern. And if we stain with CD34, we can see that all the neoplastic cells are strongly positive for CD34. But here, if you look thoroughly, you can find mitotic figures here and there. And again, when we pay more attention, we see that these areas are more cellular, and the arrangement is somehow different. Maybe they are going to arrange in more long, elongated fascicles. So again, I emphasize that we have to be sure that we are representative of all parts of the tumor, because these kinds of tumor can show areas of sarcomatous transformation, fibrosarcomatous transformation, which I'm going to discuss. Okay, and please pay attention to staining of CD34 in this slide. As you can see here, compared to previous slide, neoplastic cells showed diffusing reaction for CD34. Here, the expression is decreased. So the diagnosis was DFSP, dermatofibrosarcoma protuberans. By definition, it's a superficially locally aggressive fibroblastic neoplasm with storyform growth pattern. Head and neck is one of the most common locations. It tends to affect young and middle-aged adults. And on gross examination, they are ill-defined nodular structures with ill-defined borders. As you saw in infiltration of underneath subcutaneous adipose tissue, they are ill-defined. On microscopic examination, they can show different features. The classic pattern is the pattern we saw in first and second slide. It was located in infiltration to the location superficially with infiltration to subcutis, and creating a honeycomb appearance. They can be pigmented, they can be myxoid, but the most important one, they can show fibrosarcomatous transformation. And this is very important because this pattern has prognostic significance. So when we have, when we use IHC markers to differentiate this lesion from other differential diagnosis, they tend to show diffuse immune reaction for CD34. But as I said, and as I showed you, in areas of fibrosarcomatous DFSP, we can have loss of expression for CD34 at least in half of the cases. They have a specific genetic profile, and they're locally aggressive tumors, and the metastasis is more common in the cases of fibrosarcomatous transformation. Okay, what we call story form in histopathology is got from the sometimes in some expert soft tissue. I have heard from some experts soft tissue pathologists that they story form pattern is like straw mat. Sometimes some believe that they are like windmill spinners, and so you can find this pattern intersection of spindle cells with variable sizes. So this is called story form pattern. Next case is a 30-year-old man with epistaxis and cyanonasal mass. Okay, as you can see here, infiltration of spindle cell neoplastic cells. Again, cells are spindle in shape. Areas of hemorrhage are here present. Areas of free spaces, and there are some free spaces, maybe vascular channels. We are not sure still. And then you can find areas of papillary structures like papillary endothelial hyperplasia, reactive lesions. But in other parts of the tumor, they have these spaces. Maybe when you pay more attention to the detail, you can find that maybe they are in the atypical endothelial cells. Maybe these are anastomosing vascular channels. I'm not still sure. But as you know, the lesion is still spindle in shape. The arrangement is somehow fascicular, and background is somehow fibrotic. Again, here you can find at least some of the, here you can find endothelial cells. They are somehow shows some features of hyperchromasia and atypical nuclei. And here again, sorry. And here again, you can see vascular channels. Atypical endothelial cells are present here and there. And here is a solid sheet with increased mitotic activity, as you can find them everywhere. You can see them. So this rate of mitotic activity is not tolerated in benign lesions. So we are thinking of a vascular neoplasm. We stained for CD31, which showed strong immune reaction. CD34 again showed a strong immune reaction, and Ki67 showed high proliferative activity in neoplastic cells, and this is in that solid part with increased mitotic figures that I showed you. So it seems that we in this case are encountering with a malignant vascular neoplasm. So this was an angiosarcoma, a malignant vascular neoplasm. Variably mimics the shape of endothelial cells. Soft tissue angiosarcomas are not common, but sometimes we can see them in cyanonasal lesions. Of course, overall, angiosarcomas are not common tumors. On gross examination, they can be nodular, they can be polypoid, but they are usually tend to be purple or red in color. Sometimes they are ulcerated, areas of hemorrhage, areas of necrosis can be seen. On microscopic examination, tortuous, irregular, anastomosing vascular channels creating cleft spaces are seen. Sometimes we have capillary-sized vessels, sometimes we have large vessels. Sometimes the tumor cells can be a typical spindle shape in shape, or sometimes they can be epithelioid in appearance. And mitotic figures, including typical forms, can be easily found. On IHC staining, endothelial cells tend to show positive reaction for CD34 and CD31, and better markers, more specific markers like ERG, like FLI1, they are these days more common for diagnosis of angiosarcoma. And they are aggressive tumors, really aggressive tumors. And these poor patient, although young, unfortunately, he died of the disease after a few months with metastasis to the lung. So they are aggressive diseases. Next case. Next case is a 74-year-old man with periauricular mass. As you can see here you can find imagination of surface epithelium, squamous epithelium, and underneath the surface epithelium there is a nodular spindle shape, neoplastic arrangement of neoplastic cells in a nodular pattern. The neoplastic cells again are spindle in shape. They are arranged in fascicles, creating a whirling maybe pattern, maybe. And again, you can find another nodule here. The lesion was composed of several small nodules beneath the surface epithelium. And in this slide, in this slide, you can find a mitotic figure. And another characteristic feature is extravasation of Rbcs. It's very obvious here. Lots of Rbcs are present in this slide, and they are between neoplastic cells. So the diagnosis, again, spindle cell lesion, superficially located spindle cell lesion with mitotic figures and areas of RBC extravasation. One of the possibilities, of course, Kaposi sarcoma. Kaposi sarcoma is a locally aggressive endothelial proliferation of tumoral cells, and they are mainly located in subcutaneous regions. They can be in on gross examination like patches or plaques or nodules, and they can be seen in mucosal surfaces as well. And Kaposi sarcoma is associated with HHV8. Based on epidemiologic findings, they can be classified to 4 groups. The first group is classic type. It usually happens in elderly men. Endemic African, this type is still not associated with HIV infection. Third group is AIDS associated. And fourth group is iatrogenic Kaposi sarcoma, which happens in setting of solid organ transplantation or patients who are immunocompromised. To be honest, our case was a kidney transplanted patient. On gross examination, again, as I said, the lesion can be in the shape of patch, plaque, or nodule, and ranging from small size to some centimeters. On microscopic examination, again, we say that we have vascular channels, the spindle cell proliferation. Another characteristic feature is presence of lymphocytes and plasma cell infiltration. Sometimes we can find hyaline globules. Extravasation of RBC is very helpful. So sometimes the position of hemosiderin can happen. So these features help us to come to the diagnosis of Kaposi sarcoma. Because they are endothelial in origin, they are positive for CD31, CD34, and ERG, D240. And the marker can confirm, which can confirm the diagnosis, is HHV8. Prognosis is related to degree of immunosuppression in this particular form, which has occurred in setting of transplantation. Okay, dear Professor Azmude, the first part is finished here.
Thank you very much for your very interesting lecture. There are some questions from the audience. I think it would be very nice if you tell us your opinion about these questions before proceeding to the break and the next part of your lecture. One of the questions is that why do you start with shape of the cells? When we are looking at the slides, we start with the low power. Why the pattern is not the first component of the evaluation, and why you start with the cell shape, not the pattern? It was one of the questions.
I think we can change the, for example, the order. It's not a strict rule, you know. We can change the order. It's just important, I think, it's just important to pay attention to these baseline features: shape of the cells, background, pattern of the architecture of the network, and arrangement of neoplastic cells. But I think this is no strict rule. You can approach how you feel more easy.
Yeah, thank you very much. We have Professor Boko here. I would like to know if Jerry, do you have any comments or you know, things that you want to add to the lecture about the spindle cell lesions? We don't have your voice. Probably your microphone is not.
How's that? Can you hear now?
Yes.
Okay. I just wanted to say that I can't really add much. She was so complete. It's just going to be embarrassing to follow her. That's all. Very good job. Very, very good job.
Yes, it was very good. Dr. Safar, here's another question from the audience. Of course, they're all saying thank you. We have lots of thank you over here for your nice and interesting lecture. But here's a question from one of the audiences. Most of the soft tissue tumors have a spindle-shaped cells, fibrous background, and fascicular arrangement. So what will guide us based on H&E slide to decide for further IHC markers for a particular case? And also, you know, he or she wants to know a few places for areas that there is limitation for IHC pattern. How do you decide which exact IHC marker to choose from the morphologic point of view? I think it's a question. It's a two-part question.
Okay. Yes. Well, I think because after we follow an appropriate approach, we have to make a list in our mind. In order to narrow the spectrum of differential diagnosis. It's very, I think, it's very important because as he and she, my friend, said, lots of lesions are spindle in shape and lots of them are arranged in fascicular pattern. But we have to make the differential diagnosis based on patient's age, based on location of the tumor, based on superficially located tumor, or either the tumor is located superficially or deeply located, and again, based on number of mitotic figures, at least we can somehow grade tumor in our mind. For example, we can classify that this lesion tends to be malignant, or this tends to be reactive, or it's benign, among benign lesions. So I think although lots of tumors are spindle in shape and they tend to arrange in fascicular pattern, but following an approach helps us to narrow the spectrum of differential diagnosis in our mind very much.
Thank you. Thank you very much. I think there are no other questions. I don't know if there are any comments. If not, Professor Boko, do you have any comments or suggestions?
Oh, as I said, that was really a very complete and thorough discussion of really a topic, as you know, Dr. Safar, that's a really tough topic. And it shows because you had to get into so many immunostains, and that's really necessary in that group of entities. Very good.
Thank you so much, dear Professor. So if I have time, I want to show our hospital to the audiences too. Is it possible, dear Professor Azmude?
Yes, of course. Go ahead.
So here is the IKHC, Imam Khomeini Hospital Complex. This is our hospital. It was built in 1938 by a German company. At the very original part, it was composed of this main building, beautiful building, and there was another ward in the west part, infectious diseases part, and it's not shown in this picture, of course, and another building at the east part, which is Cancer Institute, which I'm going to show you in the next slide, and we work in Cancer Institute. It was called 100 beds hospital because at that time it was a very large hospital, and it was people called it 100 beds hospital. But after about 40 years later, after the revolution, the name changed to the name of the leader of the revolution, Ayatollah Khomeini. So it's called Imam Khomeini Hospital Complex since then. And here is the building of Cancer Institute, which we have their great Professor Azmude there, and I used to go there, and my dear colleague Dr. Shakib is also works with us, and we have good memories, good of course, and bad memories from this building. Thank you so much. I just wanted to have a brief introduction about our hospital.
Thank you very much, Dr. Safar. It was a very good presentation. And I should just like to add that Cancer Institute was the first hospital-based pathology department in Iran. You know, before that, we didn't have a pathology department in the hospital. We have a comment from one of the audiences that I think, you know, it said that I think what helps in narrowing the differential is how common each soft tissue lesion is in each population. It's a comment, and the other one is, you know, here's an example. For instance, Kaposi sarcoma is common in some African countries, and so it should be included in differential diagnosis of many cases. You know, the geographic site and where we are working is important. It is added to what you said by one of the audience. Okay, if there's no other questions or comments, we can have a short break and then we will have the rest of your lecture.
Thank you. Thank you so much.
Thank you. Okay, I hope that you're not tired and because we have a second part of Dr. Safar's lecture. Without any hesitation, let's go to the second part of Dr. Hana Safar's lecture. Dr. Safar.
Okay, thank you, dear professor. I'm going to continue. The next case is a 6-year-old boy with base of tongue mass. As we discussed here, I'm just selecting this case because I want to show you that not all soft tissue cases are spindle in shape, and not all of them are going to arrange in fascicles, long or short fascicles. We also have another kinds of soft tissue. So the pattern is completely different from our previous cases. As you can see here, some nests are here present. And if you pay attention more carefully, you can see that at the center, there is no cells, and cells tend to sit around these spaces, creating an alveolar pattern. Alveoles of our lungs. Again, you can see here, cells are not spindle in shape, and the background is not, there's no specific background. We can't find any specific background here. And when we go to the high power, we can see that neoplastic cells are not spindle anymore, but they are large and somehow polygonal, and epithelioid may be in shape with a large amount of eosinophilic cytoplasm, at least some of them, enlarged nuclei, prominent nucleoli, and they are sitting around these alveolar spaces. So when you encounter a soft tissue neoplasm with alveolar pattern, in soft tissue or tongue of a in children group, or particularly in children group, you have to think about two famous tumors with alveolar pattern, alveolar rhabdomyosarcoma and alveolar soft park sarcoma. So we should have these two famous differential diagnoses in our mind. So when you want to design an IC panel, you should cover markers of smooth muscle, or skeletal muscle origin, and markers of alveolar soft part sarcoma. Unfortunately, in our center, we don't have TFE3, and we just approach to excluding rhabdomyosarcoma, and skeletal muscles were negative. But I requested a marker in the setting of absence of TFE3. You can help from get help from this marker, which is CD34. Because these alveolar spaces are somehow close together, there is sinusoidal spaces between these nests, alveoles, of course. And you can highlight these sinusoidal spaces with CD34. And it can help us in setting of poor sources setting sometimes, because TFE3 is not possible anywhere, everywhere. Okay, so CD34 highlighted sinusoidal spaces, and the diagnosis of alveolar soft part sarcoma was made. Alveolar softball sarcoma is a rare tumor of uncertain histology. Again, like synovial sarcoma. In setting of synovial sarcoma, we said that, discussed that some of the tumors are malignant sarcomas are of uncertain type, like synovial sarcoma, like alveolar softball sarcoma, like epithelioid sarcoma, like extraskeletal myxoid chondrosarcoma. They are uncertain type. Um, Localization head and neck, especially particularly in children, is one of the famous regions. It's not a common tumor, less than 1% of soft tissue sarcomas. And on gross examination, it's partially circumscribed and sometimes multiple soft tissue nodules are present. Microscopically large polygonal cells with well-defined cell borders and eosinophilic cytoplasm are seen. Sometimes in the cytoplasm, I am going to show you, we have small purple granules and sometimes rod-shaped crystals. They are very characteristic for diagnosis of alveolar soft part sarcoma. And these rod-shaped crystals can be highlighted with PSA staining. PSA beads or after congestion with estase, they still remain in the cytoplasm of the cells. On IC study, we can use TFE3, as I said, and cathepsin K. They show strong nuclear immunoreaction. It can be very helpful. But beside alveolar rhabdomyosarcoma, we have to think about other possibilities too. There are some other tumors that tend to have a large eosinophilic cytoplasm and sometimes nesting pattern, and they can be in differential diagnosis with alveolar soft part sarcoma. One of them is granular cell tumor, which tends to occur in tongue again, and another one is paraganglioma. We should be careful because granular cell tumor it shows positive immune reaction for TFE3, and sometimes it can be challenging. We have to use panel of markers again because granular cell tumors tend to show immunoreaction for S100, and it makes the diagnosis more simpler because more simple for us because they again show TFE3 nuclear reaction. So we should be careful in differential diagnosis. And paraganglioma, of course, it has its special IC markers we have used, and usually we have no problem for differentiating. And prognosis, alveolar soft part sarcoma is by definition a high-grade tumor, and it tends to metastasize to lungs, to bones, and the behavior is completely different from granular cell tumor or paraganglioma. So we have to be very careful in differential diagnosis. And this pattern is called alveolar. As you can see here, alveolar soft part sarcoma and alveolar rhabdomyosarcoma, reminiscent of alveoles of our lung. And this figure is borrowed from Enzinger and Bay soft tissue tumors, seventh edition. And as I said to you, these are rod-shaped intracytoplasmic crystals, which are highlighted by PSA staining. Next case is a 4-year-old girl with cyanonasal mass. Okay, here you can see epithelium of upper respiratory mucosa. And underneath the epithelium, infiltration of small round cells are seen. So the tumor again is not spindle in shape anymore. So we have to go to high power slides, I think. And here you can see infiltration of rather uniform small round cells. Very difficult. Lots of differential diagnosis in our mind. from lymphoma, lymphoblastic lymphomas to rhabdomyosarcomas, Ewing sarcomas, sometimes olfactory neuroblastomas, sometimes mucosal melanomas. All of them can be in differential diagnosis. So it's better to search more and scan more slides, most part of slides. All parts of our slides should be scanned. And when we go to other areas, we can find these spaces. These spaces are again somehow alveolar in shape. But you can see the cells are in this tumor small in shape. They're small, round, with hyperchromatic nuclei. Okay, so we have found some alveolar spaces. We have to approach to small round cell tumors of head and neck region. So we have to use a logical IC panel in order not to miss any differential diagnosis. We use a panel consisting of creatines, skeletal muscle markers, LCA for excluding lymphoma, and I myself usually prefer to add TDT against LCA for excluding probability of lymphoma, because anaplastic lymphomas, as you know, are sometimes negative for LCA, and I think it's better to use TDT as well in order to cover them as well. And S100 or SOX10 for excluding mucosal melanoma, CD99, NKX2.2 or FLI1 for excluding Ewing sarcoma, and synaptophysin or chromogranin for excluding olfactory neuroblastomas. And because this was, our patient is still child, I didn't think so much about the small cell carcinomas, but high-grade neuroendocrine small cell carcinomas are also in differential diagnosis, especially in adults. So the Neoplastic showed strong immunoreaction for desmin, for myogenin, and for myo-D1. So it seems that they are skeletal muscle in origin. So this case was diagnosed as a rhabdomyosarcoma. Rhabdomyosarcoma, by definition, is malignant mesenchymal tumor with skeletal muscle differentiation. Based on current WHO classification and previous classification as well, it's divided to 4 subtypes: embryonal, alveolar, pleomorphic, and spindle sclerosing type. It's a common sarcoma, particularly in children and young adults. Head and neck region is one of the most common sites. And on gross examination, they can be polypoid, sometimes poorly circumscribed. And in embryonal form, butyrate variant, they can have grape-like masses. And in spindle cell variants, they are usually firm and somehow sclerotic. Microscopically, we are going to discuss 4 subtypes in more detail. The first subtype I am going to discuss is embryonal subtype. It's composed of primitive round to spindle cells, sometimes with a scant amount of cytoplasm, sometimes with no distinct cytoplasm, hyperchromatic nuclei, sometimes scattered rhabdomyoblasts are cells, or rhabdomyoblasts are present. And in both root variant, we have a characteristic pattern. Aggregation of tumoral cells exactly beneath the intact surface epithelium. It's called cambium layer. Is very characteristic for this subtype. Another subtype is alveolar rhabdomyosarcoma. It's more frequent in adults, and the architecture is alveolar, as I showed you. Sometimes giant cell can be seen. Sometimes in areas the tumor cells are arranged in solid sheets. They are not in all areas in alveolar pattern in many cases. Another subtype is spindle cell variant, which shows proliferation of spindle cells. Spindle cells here has elongated nuclei. Sometimes again, polygonal rhabdomyoblasts are present within the tumor. And the pleomorphic subtypes. The pleomorphic subtype is usually tumor of adults. We don't expect to see pleomorphic rhabdomyosarcoma in the children. So please be careful. Sometimes you in pediatric tumors, you have areas of pleomorphism. They are more probably due to anaplasia. So be careful. Sometimes you can sign out a tumor as rhabdomyosarcoma with diffuse anaplasia in children. But pleomorphic subtype, don't call it pleomorphic subtype, because in children, pleomorphic subtype is not well defined. So try not to use this terminology in pediatric group too much, at least. And so pleomorphic subtype is composed of, is like a pleomorphic sarcoma composed of large polygonal pleomorphic cells, bizarre nuclei, and some rhabdoid cells. On IRC study, skeletal muscle markers are very useful, desmin, myogenin, and MyoD1. Sometimes SMA is positive. But please remember that in alveolar subtype, myogenin is more positive. And in embryonal subtype and in spindle cell subtype, sometimes myogenin is heterogeneous, or sometimes these tumors lack expression of myogenin, or maybe very focal. They show very focal expression for myogenin marker. And we should remember that, and we should know that sometimes rhabdomyosarcomas show positive appearance, of course, reaction for cytokratins. And we should be very careful for differentiating them from carcinomas with rhabdomyoblastic differentiation. So it's very, sometimes very difficult. Sometimes these tumors are positive for CD99, so we have to use other markers and use an appropriate panel in order to differentiate them from Ewing sarcomas. Based on genetic profile, alveolar subtypes have specific genetic profile which has significant prognostic value. And PAX fusion between PAX3 and FOXO1 and PAX7 and FOXO1 is very frequent in alveolar rhabdomyosarcomas. About up to 80% of alveolar subtype, 85% of alveolar rhabdomyosarcomas do show this fusion pattern. And prognosis depends on site, on age of the patient, and on subtype of the tumor. Alveolar rhabdomyosarcomas with genetic pattern PAX3 FOXO1 has bad poor prognosis, unfortunately. And for rhabdomyosarcoma, don't forget that favorable sites. The tumor tends to behave in some locations more favorable. For example, in head and neck areas, in orbit, in cyanonasal, it tends to have a favorable prognosis. But in parameningeal, it tends to show unfavorable prognosis. So the location of tumor is an important issue to consider. Okay. The next case is a 21-year-old female with jaw lesion. Here you can see bone trabecula, fragment of bone trabecula, and infiltration of neoplastic cells around bone trabecula. Again, the tumor looks somehow blue in low power examination. And when you go to high power slice, again, you can see that neoplastic cells are round. Sometimes they have clear or maybe vacuolated cytoplasm. Sometimes there is no distinct cytoplasmic border. And again, sheets of neoplastic cells, the arrangement is solid pattern. We don't call it fascicular anymore. They are solid sheets of tumoral cells. And again, we have to use a panel in order to exclude other possibilities. For example, malignant lymphoma, who can say that this is not lymphoblastic lymphoma. So we have to exclude it. We have to exclude rhabdomyosarcoma, we have to exclude mucosal melanoma, and after excluding all of them, based on membranous reaction for CD91, we can call it a location on which is on the jaw, which is a common location for Ewing sarcoma and age of the patient. We can say that it can be a Ewing sarcoma, but it's better if we don't have a complete and comprehensive panel. It's better, the patient is better to be checked for translocation too. So Ewing sarcoma is again translocation associated sarcoma, so it tends to be uniform in cytomorphology. It tends again to affect children and young adults. About up to 10% of cases can be seen in head and neck region. Skull base and jaw are common sites. Then cyanonasal tracts, orbit, mucosal sites even, so they can all be involved. Microscopically, they are usually cellular tumors with uniform small to round nuclei, powdery chromatin, nuclear chromatin, and sometimes nuclear membranes can be vacuolated, can be clear, and sometimes you can do POS staining, and after POS staining, you can appreciate nice granular, nice purple granules in cytoplasm of at least some of the tumoral cells. These again can be helpful for diagnosis. But we should be careful that other histological variants can exist. Some of them is atypical or large cell Ewing sarcoma. So sometimes Ewing sarcomas or neoplastic cells are not small. They can be atypical or large. Sometimes they can arrange in hemangiopericytoma-like pattern. One of the challenging patterns is adamantinoma-like pattern. Adamantinoma-like pattern is very difficult, and it can be easily missed if we don't think about it. And another pattern is a spindle or sclerosing forms. And IC study CD99 should show strong and diffuse membranous staining. Weak staining and specific staining, they are not acceptable at all. FLI1 is a helpful marker. NKX2.2 can be seen in up to 95 or 93% of Ewing sarcoma. Some of them can express creatine, some of them can express c-KIT and neural markers too. Here is a adamantinoma-like variant of Ewing sarcoma. Let's look it carefully. As you can see here, neoplastic cells are arranged in periphery in a basaloid appearance, in a palisading pattern. So when you have a lesion in head and neck area, for example, the jaw, in which neoplastic cells are arranged in palisading pattern. Maybe you are thinking of odontogenic tumors, but please pay attention. Consider adamantinoma-like Ewing sarcoma in your differential diagnosis. And unfortunately, these tumors show immunoreaction for P63 and creatines. So sometimes the differential diagnosis is differentiating is very difficult and challenging. So it's better just to think about it at least. And when you had, for example, a strong membranous reaction for CD99, B-side reaction for P63 and creatine, it's better to consider cytogenetic study in your for your definite diagnosis. Recommend cytogenetic study because it can be very, very helpful. So I just selected this picture from the Zinger because I just wanted to motivate you to think about it, because otherwise it will be missed easily, believe me. And based on genetic profile, as I said, Ewing sarcomas are among translocation associated sarcomas. ESWR1 can be joined with FLI1, it can be joined with ERG, and it can be jointed with ETV1. They are among ETS families. Another group, non-ETS families, are discussed in a new edition of WHO classification of soft tissue and bone tumors, but we are not going to discuss them now. The prognosis depends on the stage of the patient and size of the tumor, and a translocation between EWSR1 and FLI1 is associated with better prognosis. Okay, next tumor. Next tumor is a 40-year-old man with nasal cavity mass. Again, you can see upper respiratory mucosa and infiltration of neoplastic cells in nodular structures beneath the surface epithelium. It seems that neoplastic cells are again somehow hyperchromatic and so small in size. Okay, in high power slide, you can appreciate nice, small, somehow bland looking, small round cells with a fine fibrillary background. This is immune reaction for synoptophysine. So, as I mentioned previously, one of the differential diagnoses of small round cell tumors in cyanonasal region is olfactory neuroblastoma. So we have to cover endocrine markers in our IHC panel. These tumors showed positive immune reaction for synoptophysine, chromogranin, and S100. Characteristic pattern, please pay attention to characteristic pattern of S100, which has highlighted sustentacular cells around some nails. They remain around some nails. We can find them in low-grade tumors. Unfortunately, we can't see them in high-grade ones. I'm going to discuss about the grade. And this is creatinine A1 entry. In this setting, it's better to have creatinine A1 entry in your panel in order to exclude possibility of neuroendocrine tumors. Neuroendocrine tumors tend to show characteristic dot-like pattern for creatinine A1 entry, which is absent in olfactory neuroblastomas. So the tumor was an olfactory neuroblastoma. It's a malignant rectodermal neoplast with neuroblastic differentiation. The location is cribriform plate, the characteristic location. So we should think about it in cyanonasal tumors. And a gross examination is usually unilateral, sometimes polypoid, sometimes glistening gray masses, and microscopy depends on tumor grade. This is from WHO of head and neck classification of tumors. As you can see here, we can 4 grades, grade 1 to grade 4. And we have items that we should consider: architecture of the tumor, mitotic activity, nuclear pleomorphism, fibrillary matrix, presence or absence of rosettes, and presence or absence of necrosis. When we move from low grade, grade 1, to high grade, the most high grade 1, grade 4, the architecture is changed from lobular to a variable architecture. Mitotic activity should be marked in grade 4 tumors. Nuclear pleomorphism is absent in grade 1, but it's marked in grade 4 tumors. Fibrillary matrix, which was prominent in our case, is absent in grade 4 tumors. And sometimes we can find rosettes. In grade 1 and 2 tumors, we usually find homerite rosettes, but in grade 3 and grade 4 tumors, flexner interstitial rosettes can be present. Necrosis here is absent, but in higher grade tumors, the necrosis is common. So we have to grade these tumors, and the prognosis depends on the grade of our tumor. As I mentioned you, for in IC study, NSC, synoptophysine, chromogranin, CD56, S100 highlighted testicular, testicular cells. Sometimes scattered tumors can be positive, scattered tumor cells can be positive for calretinin, maybe focal reaction for cytokeratin. And prognosis, as I mentioned, depends on tumor grade. The last case is a 28-year-old female with cyanonasal mass again. As you can see here, again, neoplastic cells are arranged in sheets, I think. Some free spaces are present here and there, but they are mainly arranged in diffuse sheets. Maybe they have more variation in size compared to the actually last case, a previous case. You can find mitotic figures here, there are mitotic figures. Again, here you can, there are some of the tumor cells are somehow oval in shape, some of them are small round in shape, some of them are more elongated, and in some areas you can find brown pigment granules. They were not hemosiderin in pearl staining. Maybe there are another pigments. We have to think about it. And this is HMB45. This is Milan A, this is SOX10, and this is S100. So the diagnosis of mucosal melanoma was made. As I previously mentioned, we have to cover malignant melanoma markers in our approach to small round cell tumors, because they can mimic any other tumors, epithelial-like tumors, epithelioid tumors, spindle tumors, pleomorphic tumors. So we have to cover them in our differential diagnosis. So malignant melanoma, by definition, is malignant tumor arising from melanocytes of the mucosal region. It tends to involve most of the cases they are after 6 decades, but our patient was young, so it means that you have to consider it in differential diagnosis even in young patients. Mucosa covering oral cavity, cyanonasal tract can all be involved. On microscopic grossly, they are often polypoid. They can be pigmented sometimes. On microscopic examination, sheets, nets of neoplastic cells, sometimes in epithelioid pattern, sometimes undifferentiated, spindle shape, plasmacytoid, even rhabdoid. So we have to think about it and consider it in your differential diagnosis. Other small cell tumors, high-grade carcinomas, neuroendocrine carcinomas, and large cell lymphomas can be in differential diagnosis. IHC is fortunately very helpful. They have a specific genetic profile. In contrast to skin melanomas, which tend to show BRAF mutations, mucosal melanomas tend to show KIT mutations followed by NRAS. So BRAF checking for BRAF mutation is not helpful anymore in these cases. Prognosis, these are very poor. The prognosis is extremely poor. They are high-grade tumors and they're going to behave in a very aggressive manner. Okay, our cases are finished here. Just in in this slide, I want to review that approach, and I want to tell you that after you have narrowed your differential diagnosis, you have to design a very logical IHC panel. And based on your logical IHC panel and immunoreactions, you can reach to diagnosis. Sometimes to maybe more than one diagnosis. And sometimes you may need to cytogenetic studies to confirm your diagnosis. And don't forget to grade soft tissue sarcomas. It's very important for, and it has lots of prognostic significance. We usually use FNCLCC system for grading, but as you know, some of the tumors are not graded based on FNCLCC system. It's another topic. I'm not going to go to these details in this short course. And in this way, I'm finishing my presentation, dear Professor Azmude. And if you have any question, of course, you can feel free to send your emails to my email, which is at sinatums.ac.ir. And here is a picture from Abbasabad Garden at north of Iran, Mazandaran. It's a very beautiful place, and the picture you can see here is at the top of the mountain. You go through a jungle road and you can see a fantastic river, you have spectacular waterfalls, and when you reach to the top of the mountain, suddenly you can see this beautiful natural lake in front of you. And this place is also has historical significance. The building that you see here, the remnant of the building, which is the palace, which was built on the order of Shah Abbas Safavi as his summer palace, and he used to go there in 17th century. And I think it's a very good place both for relax and for those who are also adventurous, because they can go mountain climbing and swimming, and it's a very good place. I wanted to end my presentation with this beautiful photo from Abbasabad. Thank you very much.
Thank you, Dr. Safar. It was great. It was a very great lecture, and I really enjoyed your lecture. It was very good, very nice cases, and very nice presentation. And
all kind of you, dear Professor Azmude, because Professor Azmude is very supportive in our institute, and I'm really lucky to be with him in same institute, because we usually use his valuable comments in our practice. Thank you so much. Like always, dear Professor.
You are excellent, and your presentation was, as usual, very good. As a matter of fact, we have a lot of thanks and thank yous from the audience, and there was just one question, and during your presentation, I think you answered that question. It was about IHC staining or IHC panel for round blue cell tumor, and I think you answered the question, and I don't see any other, questions. So I think if you don't have any comments, Professor Boko, if you don't have any comments to add, we may.
Oh, nothing right now.
Thank you. Thank you very much. Of course, we will have Professor Boko after the break. Probably there is a kind of technical issues, and I think Dr. Shakib is going to tell us something about what's going to happen.
Thank you very much. Thank you very much, Professor Azmude, Dr. Safar, for your impressive presentation. If you would let us, to save time, because of a technical problem, we have to close the room for a few seconds, and I would like to invite all audience to join us immediately using the same link address. Please join us immediately after closing the room using the same link address. Sorry for the technical problem, and waiting to meeting you in few seconds. Sorry, and thank you very much.
Thank you very much, dear Dr. Shakib. Thank you so much.
You're welcome.